as usual. We'll keep an eye out for questions and we'll come to all of those at the end too. Right. And I don't have any disclosures to share. And our usual disclosures related to the program today. We're going to continue, of course, to try to mitigate bias and be evidence-based throughout. Okay, so I hope to, in the next 20 minutes or so, accomplish three things. Talk about sleep in older adults, normal and abnormal sleep, talk about assessment of insomnia, and then talk about some treatments for insomnia, both non-pharm approaches, specifically CBT for insomnia, as well as have an approach to sleeping meds as well. Okay, so if we start just talking a bit about sleep and what drives sleep, we can really summarize it in three factors. One of them is just the homeostatic forces. So the idea being that sleep deprivation leads to sleepiness. Okay, so the longer we're awake, the sleepier we become. That's one. The second thing, we can summarize it talking about the circadian rhythms. And it's actually the pacemaker, if you will, of our sleep is in an area of the hypothalamus called the suprachiasmatic nucleus. And it takes in information of all sorts. Of course, things like sunlight and melatonin, which are inversely proportional, affect our circadian rhythms, but also the other activities that we do throughout the day, when we eat, when we work, when we exercise, drink any substances or eat any substances, of course, those all affect the circadian rhythms. There's many neurotransmitters that affect sleep. You can probably infer some of them based on how our medications affect sleep and side effects of medications. Most of the neurotransmitters can affect sleep. So we can come to those later if there's some questions. We'll touch on them a little bit when we talk about sleeping meds. So what I have here is a hypnogram. And on the top is younger adults, and on the bottom is older adults. So these are kind of average population hypnogram. So these are not necessarily clinical samples. And a hypnogram looks at the stages of sleep. So at the very top of each graph is the awake state, then working down through REM sleep, which physiologically is the most similar to the awake state, and then going through the more deeper stages of sleep, stages 1 through 4. You might see a different nomenclature these days. They no longer talk about stages 1, 2, 3, and 4, but you might see N1, N2, and N3. And N3 is basically consolidating stages 3 and 4, the deeper stages of sleep. They're quite similar. So in terms of the differences in older adults as compared to younger adults, so at the bottom, what you'll see is older adults are more likely to have more periods of awakening throughout the night. Okay, and then moving across the graph is sort of hours of the night. So more periods of wakefulness. If you added up the total sleep, you'll see a shorter duration of sleep, typically in older adults, reduced what's called sleep efficiency. So that means out of the time in bed, older adults are spending less percentage of that time sleeping. We'll come back to that when we talk about CBTI. A few other things, there's less a reduced deep sleep, so less stages 3 and 4 sleep in older adults, less REM sleep. And not depicted here, older adults are more likely to nap, and they all are also more likely to have a phase advance, so meaning going to bed earlier and waking up earlier. In terms of sleep problems in older adults, they're quite common. They're common in the community, about half of older adults. They're even more common when we look at institutional settings. So about 2/3 of people in long-term care, probably higher than that still in the hospitalized settings. Interestingly, there are about 50% more common sleep concerns in females as opposed to males. Some other facts, according to StatsCan, older adults who are higher educated and higher income are less likely to report sleep difficulties. And the consequences of poor sleep are many. Not surprisingly, quality of life. Decreased sleep can be a risk factor for various psychiatric, cognitive, and medical problems. Obviously, it can take its toll on caregivers and be a contributing cause to institutional placement. And insomnia is an independent risk factor for death as well. And if we look just a slide on sleep problems in dementia For one, just to say a few things, they're quite common. Insomnia and circadian rhythm disorders probably being the most common. Parasomnias, we'll talk, they are also quite common. Thinking of things like REM behavior disorder in the synucleinopathy. So that's like Lewy body disease and Parkinson's disease, dementia. Obviously can be caused by environmental issues in people with dementia, the treatments, cholinesterase inhibitors. They're linked in many ways. So decreased sleep can actually be a risk factor for dementia. They can be a prodrome. It can be a symptom of the dementia. And interestingly, they can also be a prognostic marker. So the Kang reference there at the bottom looked at people with dementia. They tracked sleep difficulties, and they found that prospectively, people that had more sleep problems at baseline were more likely to have amyloid deposition on scans moving forward. Okay. And in terms of assessing sleep problems, this is sort of a general approach you can take to anybody who reports sleep problems of all types. Obviously asking about sleep and subjective problems with their sleep. What are the consequences in their mind of their difficult sleep? You can assess sleep with a couple of scales. The ISI is probably the easiest to use. 7 items. The PSQI is the Pittsburgh Sleep Quality Index, and it's a bit longer and used mainly in research samples. Obviously, with sleep problems, want to assess the various causes. So thinking of things like environmental causes and the activities or circadian factors, obviously substances and medications, both prescribed and recreational. Certainly many physical health problems can impact sleep, and here are some of the more common ones. Of course, nocturia and pain probably being the top 2. Sleep problems can be a symptom of virtually all psychiatric conditions. There's the primary sleep disorders that I'll summarize in a couple of minutes. Sleep diaries are quite helpful. People that are maybe behavioral support clinicians or work in institutions are probably familiar with the DOS scale to sort of map out different types of behaviors day and night. And sleep studies or polysomnograms, not for everybody with sleep problems, just for pertinent rule-ins or rule-outs, like trying to confirm sleep apnea, for example, or REM behavior disorder, like movements during the night. Okay. And in terms of the sleep disorders, so if we look at the primary sleep disorders, according to the DSM-5, they group them into 2 types. There's the dysomnias and the parasomnias. The dysomnias, one could think of are problems with getting to sleep or staying asleep or the timing of sleep. The parasomnias are abnormal stuff, abnormal events that happen during sleep. Okay. And in terms of the dysomnias, there is a condition called insomnia disorder. It's for people that have either reduced amount or quality of sleep that's not due to a secondary cause. It happens at least 3 times a week and for a minimum of 3 months. Someone could have what's called an insomnia disorder. There's circadian rhythm disorders, narcolepsy, which is a rare condition, 1 or 2 per 1,000. This is sort of the pathological falling asleep that has the tetrad that goes along with it. We can talk about if there's questions. Of course, sleep apnea, obstructive and central, obstructive being the more common one. There's other breathing-related sleep disorders, sleep-related hypoventilation. On the flip side of insomnia disorder, there's a condition called hypersomnolence disorder, and this is people that sleep at least 9 hours a night and don't feel refreshed and actually are abnormally sleepy, and you can actually measure that as well. There's something called a multiple sleep latency test, and people are just falling asleep quickly. Okay, and the parasomnias, of course, are demand clinical attention often. REM behavior disorder, I mentioned, quite common in our folks with Lewy body and Parkinson's disease, including with dementia. The behaviors can be quite striking sometimes. Restless leg syndrome, it's often caused by antidepressant medications and other things like low iron. There's the other conditions here, the last 2 are more commonly conditions of childhood and adolescence and less common in older adults. So won't get into them just in the sake of time. And then shifting to treatments. So for everybody, of course, we want to individualize treatment for insomnia. We want to try the non-pharm stuff first. We want to look at, of course, secondary causes of abnormal sleep and think of environmental causes. We'll come to CBTI in a second. If sleeping pills are needed, trying to keep them on a short-term basis. Interestingly, there's been some studies that have looked head-to-head CBT for insomnia versus sleeping pills, and actually found the CBT for insomnia to be more efficacious than medicine. So it's not always a better or a more effective tool, the sleeping pills. Okay, so we have a question. So it's going to come up on your screen if you can take a moment. Okay, and you see it there, yes. So the question is, which of the following 5 is not a component of CBT for insomnia? Oh, looks, yeah, okay. So a bit of a range, okay. It seems like evening exercise is leading. Some people are saying sleep restriction. That might change when I talk a bit more about some of these tools. But yeah, you would think that, we could end the poll there. You would think sleep restriction would not be a tool, but actually can be a very powerful tool in CBT for insomnia. We'll talk about it. Yeah, evening exercise. Exercise is good for sleep, but it's sensitive to the time. So exercise early in the day is good for sleep, not in the evening. Thanks for voting. Okay, right, let me just close that. Okay. So now moving on. So what is CBT for insomnia? So yeah, really there is 4 components. You'll see a few other things sometimes tacked on. I have a slide for those after. Sleep hygiene, kind of the basics that you probably have a handout in your office and you're saying every day to people about sleep hygiene. Then the other workhorses of CBTI, the stimulus control and sleep restriction, which I'll talk about. And then there's a cognitive piece. Of course, it's CBT, so there must be a cognitive intervention. I'll give you an example of that in a moment. Sleep hygiene, we won't talk too much about it. This is sort of kind of the basics to try to improve the chances of sleep without doing too much work. So things like setting up the environment, things like keeping a schedule, reducing substances that interfere with sleep. Exercise is good, but keeping it during the daytime, in the first half of the day. Having a light snack before bed is actually a good thing because periods of hypoglycemia can actually disrupt sleep. Not having devices in bed. We'll come back to that actually, talking about stimulus control on the next slide. Yeah. Okay. So this is a really quick summary of some of the tools for CBTI. So it might come up in the case or if you have questions. Stimulus control, it's basically a fancy term that says we don't want people doing anything in bed other than sleeping. And if you're in bed and you're not sleeping, then leave the bed. Okay, and typically there's a 15-minute rule. So don't go into bed until you're sleepy. If you're in bed, allow yourself 15 minutes. If you're still not sleeping, you should leave the bed. Do something boring. Read a book, maybe do a bit of meditation or breathing until you're feeling sleepy again, then go back into bed. Okay, and sleepy is that feeling, not just like exhausted, but sleepy is that feeling where you actually feel your eyelids starting to get heavy and you might feel your head starting to sort of nod off. That's the sleepy feeling you want. Sleep restriction, again, arguably the most powerful tool. The thinking here, I remember earlier I mentioned sleep efficiency. The idea being that people are in bed for a certain number of hours and often they're not sleeping a good chunk of that. So for example, if someone's in bed for 10 hours and only sleeping 6 hours, their sleep efficiency would be 6 divided by 10, so 60%. We want people to be targeting 85+% sleep efficiency. So what we do is we actually restrict the amount of time people can be in bed, and we do that by fixing a wake-up time, but actually forcing them to delay the bedtime. Typically, we could restrict down to as much as the actual sleep time. So in my example, if someone's sleeping 6 hours and their preferred wake-up time is 7 a.m., you would actually push back the bedtime until 1 a.m. and allow them to be in bed from 1 a.m. until 7 a.m. Likely what's going to happen then is if people don't go into bed until 1 a.m., they're going to fall asleep quicker. They're going to be sleeping more that time they're in bed. Their efficiency is going to go up. If sleep efficiency gets to 85% plus, then you can slowly, like a week at a time, move earlier the bedtime and extend the time in bed, hopefully still keeping efficient sleep. So that's the idea. So we're training ourselves to sleep when we're in bed. The cognitive part of CBTI is really looking at the beliefs people have about their abnormal sleep, the problems their sleep is causing, and trying to question that or correcting it. Classic example: somebody would think if I've had a bad night's sleep, it's more likely I'm going to sleep worse the next night. Well, actually, the opposite is true, right? If someone's coming out of a bad night's sleep, thinking of that homeostatic force, they're more likely going to actually sleep more and sleep better the next night. Good. So it's a lot of information pretty quick on CBTI, but I think we'll have a chance to come back to it. And suffice it to say, there's lots of evidence CBTI works. It's been well studied in older adults. There's even some positive reviews now for CBTI. The most powerful elements, either the total package or in particular the sleep restriction, seems to be having the most effectiveness. There is some evidence for some other what might be considered strategies that are not CBTI, things like mindfulness approaches, exercise, Tai Chi, and some soft music in the evening. There is some evidence for these approaches in older adults. Okay, and what about in long-term care? You're probably eager, especially if you work in long-term care, what works? I mean, a lot of the stuff that's done is intuitive, probably is a good idea, but doesn't necessarily have a lot of evidence behind it. It's an area where there hasn't been a lot of studies and not a lot of large or well-conducted studies. The little bit of evidence that is there says that maybe some actually bright light therapy during the day, music in the evening, activities during the day, and of course, managing the amount of noise and light. Okay, but again, not a lot of evidence. Doesn't necessarily mean, CBTI and these other approaches don't work. It just hasn't been studied, and we can share some ideas. Okay, so in the last 5 minutes or so, doing pretty good on time. Okay, I wanted to say a little bit about sleeping pills. And, if sleeping pills do need to be used, if we think about some rational approaches, it makes sense to try to use them for the shortest period possible. Many of them do have the potential to develop a physical dependency, which is less likely if used for less than a month. If they do need to be used, lowest doses. On a PRN basis, so, I mean, some people, I think, are hesitant around PRN dosing, but I think it has some advantages in this population, being it's less likely to develop a physical or even psychological dependency if it's not used every day. And you want to avoid medicines with long half-life to reduce the risk of accumulation, and obviously want to reduce the use of sleeping pills with other CNS depressants and alcohol, for example. Okay, so another poll question, that's the second and final one. Okay, so again, without any other indications, what is your preferred hypnotic of choice for older adults? What's your go-to? So benzos or Z drugs, I'm grouping them together here. Sedating antidepressants, it's a bit of a heterogeneous group: trazodone, mirtazapine, doxepine, antipsychotics, melatonin. And if you put other, that's good, but maybe tell us in the chat or the discussion phase what you like. Looks like most people have voted. All right, I think melatonin is proving quite popular, and sedating antidepressants. Interestingly, some groups, I've done this before, many more people choose the benzos or Z drugs, maybe leaning towards the Z drugs, but not that popular here. Okay, all right, thanks for voting. So I'm going to share some thoughts. Right. And spoiler alert, so, absent other indications, my preferred choices are melatonin. Then if we need something else, trazodone. And I'll tell you why in a moment. But these are generally thought of as some of the classes of sleeping aids, and others may kind of categorize them differently. But we'll kind of just say a few things about each of them. Okay, thanks for your patience for the coughing. I'm sure you could hear that. Okay. So the first group is the BZRAs, the benzodiazepine receptor agonists, benzos and Z drugs. I group them together because they have a lot of similar properties. Many of the side effects are similar. In either case, there is some evidence of short-term efficacy, but the evidence that they're helpful over the long term, or evidence that they're even efficacious over the long term, is actually minimal in the literature. And there are certainly side effects. The Z drugs are probably a little bit better in terms of having less disruption of the sleep architecture, so less disruption of the slow wave sleep and the REM sleep. But the Z drugs still have the same similar motor and cognitive side effects to the rest of the benzos. Right, and that second group that a lot of people supported was trazodone. There's a few different things here. Are the sedating antidepressants. There's a few different agents. Trazodone does have some evidence in older adults that it helps sleep. There are still some side effects, of course. Orthostasis is one. All of these medicines have the potential to affect the QT, to prolong the QT interval. Priapism is a rare side effect of trazodone in males, of course. Mirtazapine, there's no good evidence that it helps sleep other than in older adults with depression, with prominent sleep issues. So in that population, might be a good choice. The TCAs, again, there's concerns, of course, about the cardiac and anticholinergic effects. Doxepine is liked by the American Academy of Sleep Medicine, albeit at a very low dose, less than 6 milligrams. It's often used quite a bit higher doses. But it does have some particular evidence, doxepine, but risks. Melatonin products, there is some evidence for melatonin in older adults. It seems to be pretty well tolerated. It may have some other indications as well. It's a second-line treatment for REM behavior disorder, certainly is a first-line treatment for circadian rhythm disorders. There's a bit of evidence too that it may help delirium prevention in people that are high risk, although that's, I think, debatable. There's a melatonin agonist that's approved in the States, but called Ramelteon or Rosarem, but it's not yet approved in Canada. But it seems to have some evidence and be tolerated. Maybe we'll see it here. And then there's some others, just briefly. Antipsychotics, yeah, nobody seemed to be a fan of antipsychotics. I think there's good reason for that. There's many side effects. There's the black box warnings in people with dementia. Many of them are very anticholinergic. Antihistamines, and the main issue here is that antihistamines are generally quite anticholinergic and quite deliriogenic as well. Okay, albeit many of the over-the-counter sleep aids are strong antihistamines. Okay, lemborexant, so Dayvigo. It's approved. You probably got some experience with it. I'd love to hear it. It actually doesn't have, that I could find as of recently, any specific studies in older adults. And I checked the monograph. It says this product is not specifically studied in older adults, but there is a related medicine called suvorexant, or Belsomra is the other name for it. And that does have some evidence in older adults. I've used it a bit. I've had, let's say, mixed results with Dayvigo. And magnesium does have a bit of evidence as well. There's one positive RCT, so especially people that want to keep to an over-the-counter approach, magnesium certainly can be considered. Things like valerian, it's a GABA modulator, not that well studied. The safety is not so clear in older adults with valerian. Cannabis, we could have a whole discussion about cannabis and its effect on sleep. Cannabis actually has a similar effect on sleep as alcohol in that it might help initiating sleep, but it can affect the sleep later in the night by reducing the slow wave sleep and REM sleep and actually cause more awakenings. So cannabis is not a panacea as it relates to sleep, at least not yet. Okay, and then just a few resources to finish. Some great ones for clinicians and patients here. The Canadian Sleep Society has some good resources for everybody. If you're a family doctor, especially, you know about the WELL through the Center for Effective Practice, and it has some great tools for clinicians. There's been some good work in Canada around deprescribing, and the Canadian Deprescribing Network has produced, in particular, a brochure that helps people to reduce use of benzos, something called the Empower brochure. And mysleepwell.ca or Sleepwell is a great website by Dr. David Gardner, who's a pharmacist in Dalhousie, and a few other apps at the bottom as well. There's a good one, people that like apps. CBTI Coach was developed through the US Departments of Veterans Affairs, and it's a great app and it's still free, actually. So check out CBTI Coach, especially for patients who are tech savvy. Okay. Great, and that's happy to take some questions too. I'll stop sharing.
All right, thank you very much for that, Dr. Kitamure. So we do have some questions here. So one of them, I think Tara had asked about was the CBTI resources, which I think you've addressed already.
Thanks. I'll put it back actually, because I think I went through it pretty quickly on that slide. It was just that last slide. Yeah, I like the clinician manual that I use is a cognitive behavior treatment of insomnia. It's by Perlis, is the author. I don't think it's been updated in a few years. So that's the Perlis text. And the insomnia workbook is a good CBTI kind of self-help book for patients. And there's some good stuff on the Sleep Well website too.
Okay, and so I'll ask Irene if you want to ask your question about hypnograms and sleep drive.
Hi there. So my question is, looking at the hypnogram, it looks like the architecture is quite different with the older adults. Does that mean this is a change due to like physiological changes, like for example, just needing to use a washroom more or other medical issues, or is it because their sleep drive is different?
Yeah, I think it's not just, you know, the physical health and nocturia that's interfering. There is a change, you know, in the underlying sleep architecture. For example, right, there's a change in the number of awakenings, not just to go to the bathroom. Many of the awakenings actually that you and I would have also are actually outside of our awareness. They're almost like fleeting and momentary, where our body wakes up and then almost drifts back into sleep. And the one thing I didn't say, I don't think clearly, is it's not necessarily that the body needs less sleep. So yes, that older adults are sleeping less on average, but there's also more, people are also more likely to complain of sleep problems and have adverse consequences as they get older, right? So it's not a general statement that people need less sleep, so it's no problem, right? People are sleeping less, but also that is problematic.
Okay, thank you. And Scott, did you want to comment on the question around magnesium?
Or I could find it if Scott stepped away. I was just trying to see it. Can you read it out?
Sure.
About dosing?
Yeah, just dose range for melatonin recommended for geriatrics.
For melatonin, yeah, melatonin's an interesting one. You know, dosing and timing, you're going to see wide range of suggestions, and I think the evidence is not so clear exactly what the right dose or when to take it. I usually direct people for melatonin to the over-the-counter strengths, which would typically be 3 or 5 milligrams. One thing to say, there's a bit more evidence for the slow release forms of melatonin, so I do direct people to try slow release if they haven't already bought something. Typically would start it at 1 tablet, so 3 milligrams or 5 milligrams, and typically the max dose that I suggest is about 10 milligrams. If you're treating like REM behavior disorder, there's some evidence to go even higher than that. But for sleep, less than 10 milligrams. And I usually tell people to try it at least an hour before their desired sleep time. Now, there's some people that really believe you need to take it many hours before sleep. I haven't seen that so clearly. I think if it works for people, typically an hour, 2 hours before the desired sleep time is a sweet spot for most.
Okay. And Maria had a question about about magnesium.
Oh yeah. So I thought I heard magnesium. Yeah. So typically, some of the evidence would say about 50 to 100 milligrams of magnesium. Okay, would be the typical dose. So I think you can get it in that strength over the counter, if I'm not mistaken. Yeah.
Great.
Just on the topic of melatonin, and I see the question about like, how long should you use it for? And I think there are theories that is taking exogenous melatonin over the longer term, is that naturally going to suppress your own production of melatonin? I think that's a bit more of a theory. I'm not sure if that's a legitimate risk or if that's actually been borne out. So I do have some people that are taking melatonin over the longer term, and it seems to continue to work and not pose an issue.
Okay. And Claire Checklin just commented on mysleepwell.ca. That's one that I'm well aware of as well, being a Nova Scotianer. All right. And Amanda, did you want to talk about the sleep journal?
Yeah, I was just wondering how you ask the clients or how you get them to like buy into it and get them to actually do the sleep journal, especially working with seniors. Sometimes that's a lot more difficult.
It's true, yeah, and there does need to be some cognitive wherewithal, of course, to complete that type of homework. CBTI does have some evidence in people with mild cognitive impairment, and obviously beyond that, I think you might need to modify the techniques. But first of all, I would tell people typically to do it in the morning. So don't keep the sleep diary at the bedside. Don't watch the clock. So we're talking about approximations. People are usually pretty good at approximating. I was up once, I was up twice. What I ask people to capture in a sleep diary would just be, when did you go into bed? Approximately how long did it take you to fall asleep? How many times did you wake up? For approximately how long were you awake during the night? When did you wake up? And when did you leave the bed in the morning? And those would be sort of the items. I try to have people do it, and you need that to get a rough sense of the sleep efficiency. Depending on people's living situation, you might be able to get a caregiver to help with that, or a DOS, right? If someone's having that done in a long-term care setting, it kind of gives you a lot of that information, right, as well.
Thank you. So Sarah Shaw, did you want to ask your question?
Yes, thanks. I was just kind of curious what the research was showing about the Fitbits, Apple Watches, and their sleep tracking. And is that something that for our more cognitively capable older adults, would you recommend they use that for that?
It's a great question. It comes up every time I do this, and I keep saying I'm going to look into the evidence, and I always fail to do that. So I'm not. I know there's those smart watches and devices will actually say you slept this much. This was your sleep efficiency. I'm not sure how accurate those are, because, and I don't know how they determine it, right? Because I mean, you can't base it just on movements, for example, right? People move in their sleep, so. Yeah, I don't know. Has anybody looked into the evidence around those tools and gadgets? But I could certainly see that could be quite helpful in calculating even just something like sleep time and sleep efficiency, right? Which is the main pieces you need to do the sleep restriction for CBTI. I'll tell you where you are. Thanks. Does anybody on here use them themselves? And any feedback from their own use to track their sleep?
I actually did buy the Apple Watch myself just to track it, and it's quite interesting and pretty accurate. Because it even shows, like, how my respirations have changed, heart rate's changed, O2 sats have changed, and it definitely correlates on those nights when I have a crappy sleep.
Very neat. Thank you for that. Yeah. And it could be one of those things, right? We're all moving towards, collecting data from patients and tech and sending it back to people. Like, we could be doing on many people, just getting their data right from those types of tools and brief sessions, right? Just to tweak the sleep schedule, basically.
Yeah, and Brenda Sutherland commented that it can increase sleep anxiety in some people, and I've certainly seen that people are get really obsessed with the data. And they're telling me exactly, at what time they woke up down to the second kind of thing. All right. So there's a question around the evidence around CBTI in the elderly from Shelley House.
Yeah, I just had one slide. I went through it pretty quickly, but there is very good evidence in CBTI in older adults. Good studies, and there's even been some systematic reviews. So it's definitely to tell people it's evidence-based. There's also actually one thing to add. They've kind of, like a lot of CBT, they tried to adapt it, with like kind of almost automated coaches to capture data, deliver it in group form, deliver it online. And there's some evidence that CBTI can be adapted and delivered in different ways too.
All right, I'm going to ask Brian to ask his question around wandering and insomnia.
Yeah, hey, thank you. We typically see many clients who, in our context, we have lots of responses for older adults with neurocognitive disease, wandering, escaping, to the extent that caregivers are locking their doors at night, causing lots of stress, and their goals are to remain at home. And so where's the balance between helping them sleep, whatever we need to do, versus the safety?
Yeah, it's true. I mean, I guess in those cases, I often think of, if we can help people to sleep more, we're kind of addressing two problems at once, right? Some of the risks of those behaviors. And I mean, I guess there's two pieces. More commonly, you might have people that are waking up and wandering, right? I guess at the extreme form, you could actually have a REM behavior disorder, right? Where somebody is actually in a sleep and up and moving, right? And I've seen that a couple of times as well. And there's some treatments just for REM behavior disorder, so melatonin, clonazepam for REM behavior disorder. But yeah, it's, I mean, I'd be curious how people approach that. I mean, in those cases, even, things like some of, locking the door and alarms, obviously alarms probably preferable to locks for safety reasons, but, and obviously, trying to promote dignity as well, right? You don't want people to be kind of restrained in their environments, but yeah, it's a neat space. Any pearls that you found in terms of addressing that type of issue, or anybody?
Just like to make sure they're not wandering the street in the middle of the winter.
Yes, wandering can really be an emergency quickly. Thank you.
All right, thank you, Dr. Kitamure. So I know there are more questions there, but unfortunately, we're going to have to move on to the